of sessions that we're going to run on a Tuesday morning. They're meant to be fairly short, sharp sound bites, really, just to look at some of the basics of some of the procedures that we see in patients. And they're not really in any particular order, to be fair. Some of them are been juggled around a little bit, just dependent on speakers' availability. So the first thing that we're going to look at is transposition of the great vessels, and we're going to look at the arterial switch procedure. If my slides will move on. Which they won't. So transposition of the great arteries, you can see on the panel on the right hand side a picture of transposition of the great arteries. So this is when we have right atrium connecting to right ventricle, connecting to the aorta instead of to the pulmonary artery, and left atrium connecting to the left ventricle, connecting to the pulmonary artery, obviously, instead of the aorta. So the great vessels are transposed and connected incorrectly. It accounts for about 5 to 7% of all congenital heart disease, and 20 to 30 per 100,000 live births. So in Leeds at the moment, we have around 10,000 deliveries. It's quite useful because it allows the maths to be very easy. So just from the Leeds catchment area, we see around 2 to 3 babies born a year with transposition. And for the whole of the catchment area, that's around 10 to 12 babies born with transposition every year. It's rarely associated with any syndromes or any other extracardiac abnormalities. So transposition is usually the only thing that's wrong with them. And there is a male preponderance. And these babies are born, and they're kind of renowned for being big, healthy, chunky babies. So they don't have any in utero issues at all. So they're always nicely grown, and they look nice and chubby when they're born. It's a bit commoner in infants of diabetic mothers, and as we've already looked at, what we have is ventriculo-arterial discordance. So the wrong great vessel is attached to the wrong ventricle. And as a neonate, this presents with cyanosis. So as the PDA closes, so you can see on the image the PDA connecting the pulmonary artery to the aorta, which allows mixing. So as the PFO closes and the PDA closes in the first few hours after birth, the babies become immediately cyanosed. And with this condition, around 90% of them will die in the first year of life without any definitive treatment. Now, transposition is one of the things which really we should be able to diagnose on fetal scans. So on 20-week fetal anomaly scans, babies who have got transposition, this should be picked up. And that is happening in greater and greater numbers. There are still some that are missed if their views are difficult. But one of the standard fetal echo views is looking for crossing over of the great vessels. So as you can see in the image, the great vessels are parallel in transposition, whereas in normal arrangement, they cross over, and that's one of the specific views. And it's really important that this is diagnosed in fetal life, because babies that have a restrictive atrial septum, so a very small interatrial communication, they can get critically ill very, very quickly and in the first few hours of life. And we recommend that these babies are born in Leeds so that they can have atrial septostomy performed very, very quickly. I'm just going to try and get this to move on. So I really like the history of the surgical treatment for transposition. And I think it's quite interesting for those of you in the audience who are as old as I am or older, no names mentioned, but to put yourself in this kind of timeline and see where you would have been had you been born with transposition. So it's a great history. So if we start in the 1950s, this is really at the start of interventional cardiac surgery. So 1952 was the first atrial septal defect repair, and that predates any kind of cabbage or valve replacement. So the first treatment for transposition was surgical atrial septectomy. So this was performed in the 1950s and is a palliative procedure essentially, which allowed deoxygenated and oxygenated blood to mix at atrial level, so that the blood that was going out to the aorta was not as deoxygenated, so it wasn't as blue as it would have been had there been a proper atrial septum. And in these kids, it may have extended their life by a couple of years, but they would have been poorly and cyanosed and not very happy, and was certainly not a long-term solution. In the early 1960s, atrial septectomy was superseded by a procedure called the Senning operation, and that was fairly rapidly followed by one called the mustard operation. And these two are technically slightly different, but physiologically are the same. And these are the atrial switch procedures, and we have got a session booked in to talk about atrial switch. But these had a preoperative mortality of around 5 to 10%, perioperative mortality of 10 to 15%, and a late mortality of around 20%. The oldest survivors are now in their 50s. We have around 150 of these patients on the books, but they have significant late morbidity and a markedly reduced life expectancy. So we wouldn't really be expecting to see any of these patients survive into their 60s or older unless they've been transplanted, and that's pretty few and far between, I'm afraid. Without giving away secrets, I was born in 1970, so I would have been somewhere in between the mustard operation and introduction of the arterial switch, but would definitely have had an atrial switch. So if that was me, I would have been looking at death in my 50s, which is a bit depressing. So in the late 1970s, the arterial switch was introduced, and that's now standard practice across the UK. So, for example, in the financial year 2015 to 2016, there were 143 arterial switches performed in the UK, and they had 100% one-year survival, which is phenomenal, really. So what is the arterial switch? So it's now the operation of choice for simple transposition, and it's usually performed in the first 2 weeks of life. One thing to say about this is obviously babies are quite small, and when babies are born, the heart is about the size of a strawberry. So this is surgery that's performed on a heart the size of a strawberry. And actually, if you ever get an opportunity to come and watch any of the paediatric cardiac surgery, this is the one to watch, because it is actually phenomenal how they do it. So what do they do? Well, the aorta and the pulmonary artery are detached from their native routes, and they're reattached on the opposite route, which re-establishes ventriculo-arterial concordance. Sounds pretty simple, really. So just switch the arteries back over and make it all back to normal. The problem is that the coronary arteries are translocated on buttons. And I'll show you a little bit more detail about this. And this is what makes the operation technically quite challenging. And it's the arterial switch procedure that was the one operation which caused issues in Bristol. So some of you will remember the Bristol inquiry looking at excess deaths among babies operated on in the congenital heart unit in Bristol in the 1970s and early 80s. And it was the arterial switch procedure which had high rates of mortality, and that's related to problems with the coronary artery anastomosis. So this is the heart with transposed great arteries. So you can see here right atrium, right ventricle leading out to the aorta. And the thing to note is that the coronary arteries come off the native aorta as normal. And this valve here, which I'm not sure, can you see my pointer? Hang on. So this valve here is the aortic valve, is structurally the aortic valve because it's attached to the aorta, and the coronary arteries, as you can see here, arise from the aorta, which is attached wrongly. And then again, you can see left atrium, left ventricle, pulmonary artery. So this is how the arterial switch is done. The two great vessels are cut off and then switched over. So the pulmonary artery has been reattached here onto the right ventricle, and the aorta has been reattached onto the left ventricle. What's left in place, however, is what was the native aortic valve is now the pulmonary, and what was the native pulmonary valve is now the aortic. And you can see that these coronary arteries have been taken off and moved and re-implanted back into the aorta. You can't simply cut it off below the coronaries and pull the vessel over, because you'll induce lots of stress and strain and twisting on the coronary arteries, and you can't really do that. You'll also see in this picture the arrangement of the pulmonary arteries, and we'll talk a little bit more about how the pulmonary arteries are put back into a position. It's not a normal anatomical position, but it is a position. So I was just looking for some most recent outcome data. So this is a paper which has only just been published electronically. It's not yet out in paper form. And this is long-term outcomes of the arterial switch procedure. And this is a single Australian centre, I think it's in Adelaide, 844 patients who underwent arterial switch between 1983 and 2015. You'll see this shows absolutely outstanding long-term survival. So this is obviously day 0, and there's a tiny bit of attrition at the point in time perioperatively and in the very early post-operative period, and then going out to 25 years post surgical follow-up, there are no deaths in that period of time. Obviously, the follow-up data is not complete for all patients, so this is only includes 95 patients out at 25-year follow-up, but really shows outstanding long-term survival. So are there any long-term problems with the arterial switch? Well, there are, and there are certain things that we do see and that we are on the lookout for, which are common enough that we do keep all the patients under regular lifetime follow-up. So the things that we see are multi-level right ventricular outflow tract obstruction. We see neo-aortic root dilatation and resultant neo-aortic regurgitation. We don't generally see coronary insufficiency, but there are centres internationally that do see quite a lot of coronary insufficiency, and this is particularly related to surgical technique. So we don't have a problem with this. I can't remember a single patient that we've ever had issues with late coronary insufficiency, but we'll talk a little bit more about that. So why do we get multi-level right ventricular outflow tract obstruction? So this is related to how the arterial switch procedure is performed. So you can see in this image here, this is the start. So the pulmonary artery is posterior and the aorta is anterior. And this is the procedure being done. So the coronary button's being taken off. This is the aorta being stitched back on to above the left ventricle. And this is the pulmonary artery being stitched back in place in front of, on top of the right ventricle. So the pulmonary artery is brought right round to the front. And there's a procedure called the Lecomte manoeuvre, whereby the two branch pulmonary arteries are slung around the aorta. So the anatomical arrangement is entirely different to a normal pulmonary artery aorta arrangement. You can see it in this cross-sectional imaging here. This is aorta, and this is this pulmonary artery that's been slung. The branches have been slung around the aorta. And what we quite often see is there's not much room between the aorta and the sternum. So this often gets a bit squashed here. There's quite often not much room between the aorta and great veins. So this often gets squashed. And because this journey from these branch pulmonary arteries where they branch out to this area at the front is longer than normal, these pulmonary arteries are often stretched and elongated and a bit squashed. So we often see problems with pressure loading, so stenosis and narrowing at the top of this bifurcation here as it sits behind the sternum, and then in these branch pulmonary arteries. You can see it quite nicely on this picture here. So this is the re-anastomosed pulmonary artery, and it gets squashed behind the aorta and then these branch pulmonary arteries. So we see it at lots of different levels, at right ventricular outflow tract, at the level of the neo-pulmonary valve, at the PA bifurcation, and at the branch pulmonary arteries. And because of the anatomical difficulties, it's quite difficult to treat. So if we've got long, skinny, stretched branch PAs, we can stent them, but we can't get around the fact that they're long and skinny and stretched, and we can't make them juicy and fat. So we're slightly limited in terms of the anatomical substrate. Neo-Aortic Regurgitation is something that we do see fairly commonly. So in this Australian series of 844, but with 95 patients, I think with 25-year follow-up, they reported 44 operations in 34 patients. And it's a late complication, so a median of 14.5 years post-surgery. So this is something that is really the domain of adults having had the arterial switch, rather than something that's seen in paediatric practice. And it's related to dilatation of the neo-aortic root and the neo-aorta. So you can see in this cross-sectional image here, this is what we do tend to see in these aortas. And you can see that that one measures 5.1, and you can see how big it is in the 3D reconstruction and the impact that that's having on the branch pulmonary artery. So this is the LPA here, right pulmonary artery, and you can see that the stretch on this aorta is having an impact on these pulmonary arteries as well. So it pulls apart the neo-aortic valve and causes it to regurgitate. The other thing it can do is, as this aortic root stretches, it can twist and tort, and it can cause compromise of these coronary artery buttons, just as everything changes its relationship slightly. And this is usually progressive fairly slowly, but usually eventually requires mechanical aortic valve and root replacement. Occasionally we have a patient who is very not keen on a mechanical valve, and they are able to persuade our surgeons to put in a tissue valve, but it's fairly few and far between. And the reason for that is the patient's obviously already had surgery. For us to get to replace the aortic root, we have to take down all of this Lecomte maneuver. So the pulmonary artery's got to be redisconnected and all taken off the aorta, so that you can redo the aortic root, and then the PAs have to be reconnected to the right ventricle. So it's extensive surgery. You've got to redo the coronary anastomosis as well. So this is not surgery for the faint-hearted, and the surgeons would very much prefer that this is a one-off intervention. So a mechanical valve is almost always the choice. So how often are we needing to do these interventions? Well, again, this is from this Australian series. This is freedom from re-intervention. So you're looking out at 25 years, around 75% freedom from re-intervention, which, if we compare that to long-term outcomes in the atrial switch procedure, so mustard and Senning operations, is really, really very good. And these are the kinds of procedures which are done. So what we've already talked about, issues with right ventricular outflow tract and pulmonary artery. So branch pulmonary artery stenosis repair, main pulmonary artery repair, pulmonary valve replacement, and then aortic root replacement in 18, valve repair, valve replacement. So these are the main things that are happening, you know, with occasional permanent pacemaker, sub-AS resection, sub-PS resection, and then quite a lot of catheter intervention as well. So branch pulmonary artery, balloons and stenting. This is, you know, mostly right-sided intervention, and then a couple of associated defects and other things that have been done in the cath lab. But again, really excellent long-term outcomes in terms of freedom from re-intervention. I've mentioned the coronary arteries a little, and I've also said that we haven't seen much in the way of problems with coronary arteries, and I kind of think that's a not yet. So I worry about coronary arteries which are handled as a neonate. They've been re-implanted. What will the implications of that be in the long term for atheroma development? So the coronary artery anatomy is slightly wonky, and will there be changes to endothelial function, shear stress, and will there be issues related to proximal coronary artery atheroma in the longer term? I'm very, very keen that they don't smoke. And I'm also very keen that they look after themselves in terms of other lifestyle factors and don't get overweight. One of the things that is quite important is we had one patient who came with chest pain and who did look to have slightly abnormal proximal coronary anatomy on a coronary CT. So we went to the cath lab to try to do an FFR, and our coronary intervention team found it really challenging to get into the proximal coronaries because the anatomy is completely abnormal. So you can't just assume that you're going to be able to use standard coronary catheters or guide catheters if there are problems in the future. So that's going to be another challenge and add to everybody's interest, really. What about pregnancy? Again, because these guys are fairly young, probably going back 10 years ago, we didn't have very many who'd been through pregnancy, but now those numbers are increasing. It's pretty much low risk for mothers. So if they've got no significant issues in terms of right ventricular outflow tract obstruction or obviously significant aortic regurgitation or significant aortic root dilatation, then pregnancy generally is low risk. And the other good thing is that transposition is not very inheritable, so it's one of the least inheritable conditions. So the risk for babies being born with congenital heart disease themselves is low risk as well. So arterial switch for transposition, it's a life-saving and life-changing surgical development and a massive step forward from the atrial switch, which was done until the mid-1970s. And it has amazingly good medium-term outcomes. So the main issues, as we've discussed, are related to multi-level right ventricular outflow tract obstruction and neo-aortic root dilatation, which leads to aortic regurgitation. And there may be problems in longer term follow-up with the coronary arteries. And that really is a kind of watch this space moment. And that's all I have to say for this part of the session. I'm just going to come out of screen share. Oh, David, you're there. Sorry, you just came up straight on my screen.
Okay,
and
sorry.
I don't know if there are any questions in the chat or if anybody wants to put anything in the chat. So any questions based on that part? And we'll just give you a few minutes and then we'll move on to Joe's, and I'm going to slide share Joe's slides as well. So anybody, any questions at all? Okay. So I'm going to share Joe's slides.